Hi, my name is John Park, and I'm one of the physicians at Carolina Conceptions in Raleigh, North Carolina. I'm going to be talking for a few minutes about preimplantation genetic testing. Preimplantation genetic testing, or PGT, refers to the ability to detect genetic abnormalities in embryos created through in vitro fertilization prior to becoming pregnant. Now, the most common form of PGT is for aneuploidy screening. Aneuploidy refers to the presence of an abnormal number of chromosomes within the embryo. Every embryo is supposed to have 23 pairs of chromosomes. One set of 23 come from the egg, and the other set of 23 come from the sperm. So if there's an abnormal number of chromosomes, such as 45 or 47, that embryo is aneuploid. And common examples of aneuploidies would be Turner syndrome or Down syndrome. Now, a euploid embryo, on the other hand, has the correct number of chromosomes, which is 46. Now, aneuploidy typically occurs when the egg has an abnormal number of chromosomes even before it was fertilized. So instead of having 23 chromosomes, an egg might have 22 or 24. That egg may become fertilized and develop into an embryo, but that embryo would be aneuploid. An aneuploid embryo often will develop poorly within the laboratory during the first few days, but many aneuploid embryos will still develop and have a normal appearance. In most cases, aneuploidy is lethal, and the embryo will stop developing at some point. It might be in the very early stages within the IVF laboratory, but like I said before, some of those embryos will still develop and have a normal appearance. Aneuploid embryos may be selected for transfer, but they might stop developing shortly after that and fail to implant. Aneuploidy is one of the leading causes, if not the leading cause, of failed implantation. We also know that some aneuploid embryos, once transferred, will implant, but eventually miscarry because the embryo fails to continue developing after 5 or 6 or 7 weeks. And we do know that aneuploidy is the leading cause of first trimester miscarriages. So the exclusion of aneuploid embryos provides a clear advantage over embryos that are untested, as untested embryos always have some chance of being aneuploid, and if so, will fail to develop into a normal pregnancy. Using preimplantation genetic testing for aneuploidy screening will maximize the chance of a healthy pregnancy by maximizing the chance of a successful implantation, but also minimizing the chance of having a miscarriage. Because egg quality declines with age, PGTA becomes more beneficial when women are in their mid-30s or older. As women age, egg quality declines, and as egg quality declines, those eggs are more prone to making an error in meiosis, and that would result in an abnormal number of chromosomes prior to fertilization. As you can see in this graph, the percentage of biopsied embryos that are aneuploid will increase with maternal age. Eggs with an incorrect number of chromosomes can fertilize and still develop into embryos, but they will have an aneuploidy, such as Down syndrome. So as maternal age increases, there is a natural decline in egg quality, leading to higher rates of errors in meiosis, leading to a higher proportion of aneuploid embryos. So as I said before, doing preimplantation genetic testing for aneuploidy screening will maximize the chance of an embryo implanting, but also minimize the chance of that pregnancy resulting in miscarriage. Taken together, this increases the chance of a successful live birth per embryo transfer. We have much greater confidence with embryos that we know are euploid. This allows us to confidently do a single embryo transfer, and it reduces the risks associated with multiple pregnancies, such as twins and triplets. So PGTA will reduce the time to a successful live birth because it reduces the number of failed attempts that one might go through. Now, it's important to understand that doing PGTA does not increase the number of euploid embryos. It only helps us identify those that are euploid. Now, in some cases, we might find that we don't have any euploid embryos out of a set of embryos that undergo testing. And though that's disappointing, it's important to understand that there is a benefit to recognizing that early. And it will prevent the patient from going through a number of failed attempts with either negative pregnancy tests or possibly pregnancies that end in miscarriage. To demonstrate the benefits of PGTA on in vitro fertilization, let's take a look at data from Carolina Conceptions from 2017. We can compare outcomes of non-biopsied embryos to biopsied embryos. As you can see in this graph for non-biopsied embryos, pregnancy rates in women under the age of 35 were 67%, and there was a gradual decline with increasing age that is expected, so that in women between the ages of 35 and 37, pregnancy rates were 63%, and then they declined to 58% in women over the age of 38. But this second bar shows the actual live birth rate per embryo transfer using non-biopsied embryos. And you can see there's a more dramatic decline as age increased. Now, the difference between the pregnancy rate and the live birth rate represents the pregnancy losses or miscarriages in each age group. So as you can see, the rate of pregnancy loss increases with increasing maternal age, a trend that's seen even in spontaneously occurring pregnancies. Now, if we look at the outcome of euploid embryos, as you can see, in women under the age of 35, pregnancy rates are a little higher at 75%. They're similar for women between the ages of 35 to 37 and even 38 to 40 at 74% and 81%. In women over the age of 40, we only had 3 embryo transfers that year, and 1 out of those 3 became pregnant. But more importantly, when you look at the live birth rate, you can see that the live birth rates are very similar to the pregnancy rates. With euploid embryos, the difference between live birth rate and pregnancy rate is much smaller because there's a much lower incidence of miscarriages with euploid embryos. One of the questions I frequently get from patients is whether there are any risks to embryos by undergoing the biopsy procedure, and the answer is yes. The skill of embryo biopsy is a very difficult one to master. We've seen from a number of studies that the potential for an embryo to implant and turn into a normal pregnancy, even though it's euploid, can be reduced in certain situations. We've seen from some studies that there is a potential to harm an embryo and reduce its ability to result in a successful pregnancy. It takes a lot of practice to perform embryo biopsy so that the DNA integrity of the cells removed is preserved while minimizing trauma to the rest of the embryo. For this reason, some clinics will have better outcomes with PGTA, so it's important to ask about clinic-specific pregnancy rates and live birth rates. Evaluating the live birth rate per embryo transfer in the first embryo transfer as well as subsequent embryo transfers is a way of evaluating how well a clinic does with the PGTA process. All clinics who are a member of SART, which is the Society for Assisted Reproductive Technology, is required to report outcomes to that organization. And one can go to the SART website at sart.org to see national statistics as well as statistics for individual clinics. One can look at clinic-specific outcomes on the SART website and use the PGT filter to look at the differences in outcomes for a clinic depending on whether or not embryo biopsy was done. More recently, we've discovered that a small percentage of embryos appear to have cells with 2 different chromosomal complements. These embryos are called mosaics, and it appears to occur in about 5% of embryos. This is an error in mitosis, an error that occurred after fertilization during the early stages of embryo development. Now, in some cases, the mosaic has a high proportion of chromosomally abnormal cells and a small percentage of cells that are chromosomally normal. Now, these embryos are still considered abnormal, and we would not use those. But some mosaic embryos are mostly normal cells, but only a small percentage of abnormal cells. These are called low-level mosaics. These low-level mosaics still have the potential to result in a normal, healthy baby. So at Carolina Conceptions, we still feel comfortable transferring low-level mosaic embryos. After all, if we weren't doing PGTA, we would be unknowingly transferring mosaic embryos as well as abnormal embryos. There's a number of current reports in the literature showing that the transfer of low mosaic embryos can still result in a normal baby. Now, the chance of implantation and miscarriage isn't quite as good as an embryo that's diagnosed as euploid, but there's still good potential for having a healthy pregnancy. It is strongly recommended that an amniocentesis is performed in the second trimester to evaluate the chromosomal complement of the fetus and make sure that it's chromosomally normal. So in summary, PGTA is a very powerful tool to help us evaluate the health of an embryo in a far more informative way compared to the standard process of morphology grading. This reduces the number of embryo transfers procedures needed, and it provides us with a more efficient path to a successful pregnancy.